When the discharge papers are finally printed, there is a distinct, universal feeling of relief. The procedure is done, the nurse has reviewed the medications, the patient is officially cleared to leave. But the moment those hospital doors slide shut, the environment changes. For days or weeks, the patient has been surrounded by a controlled system of visiting nurses, monitoring equipment, and specialized beds. At the exit, that professional safety net is removed. The weight of care coordination shifts to the family. In the 5-minute walk to the parking garage, a spouse or adult child becomes responsible for managing medication instructions, physical support, and the immediate safety of someone in a fragile state. This creates a logistical gap between the hospital room and the living room, a period where the professional oversight of the clinical staff is replaced by the private resources of the family. Faced with this sudden shift in responsibility, the immediate caregiver instinct is to grab the keys to whatever vehicle is parked at home and try to make it work. A family member might be willing to help, but their intentions clash with physical reality. Someone recovering from knee surgery may have a leg braced straight. Another patient might be dizzy from lingering anesthesia, dealing with core weakness, or relying on a wheelchair. This wireframe diagram maps the spatial trajectory needed to get into a standard family car. Look at the deep drop required to fall into the passenger seat of a low sedan, or the steep climb to reach a high SUV floorboard. These everyday angles are incompatible with restricted mobility. Forcing a stiff joint into a small doorframe or relying on a spouse to hoist you risks injury to the surgical site and the caregiver's back. Add in a crowded hospital loading zone, an impatient line of cars idling behind you, and a patient who feels rushed and embarrassed, and the risk of a fall increases. Relying on a standard car without accounting for the passenger's physical condition takes a medically stable person and turns them back into an at-risk patient before they even pull out of the driveway. This logistical gap is where non-emergency medical transportation, or NEMT, functions. It is a transit system engineered to provide the same physical support found in a clinical setting during the drive home. To understand how NEMT works, we have to draw a strict line between this service and a 911 emergency ambulance. They serve different purposes. If a patient is experiencing chest pain, active bleeding, or sudden confusion, that requires a 911 emergency ambulance. If someone needs active medical treatment or life-saving intervention during the ride, a scheduled transport is not the answer. Look at this decision tree matrix. If the patient requires treatment in transit, they follow the red path to emergency transport, but if they are medically stable, they follow the blue path to NEMT. NEMT vehicles are mechanically adapted to the passenger. That means onboard securement systems for stretchers, hydraulic lifts for wheelchairs, and trained personnel who provide support. The service is focused on logistics rather than medical treatment. It ensures the mechanical capabilities of the vehicle match the physical limitations of the passenger. Executing that match requires coordination, and that planning must start before a nurse announces the patient is cleared to leave. This post-discharge risk assessment highlights the logistical questions a family needs to ask the facility early. Can the patient sit upright? Are there sedation precautions? Does the destination have stairs? Getting those answers is critical because hospital discharge timelines change. A scheduled morning departure can stretch into the late afternoon while you wait for a final doctor's sign-off or a delayed pharmacy reconciliation. A rigid taxi schedule will fall apart under those conditions. A professional NEMT provider communicates with the facility staff to track those shifting timelines, adjusting their arrival so the patient is never rushed and never stranded on the curb. Anticipating this logistical friction and gathering accurate mobility data early replaces a chaotic scramble with a coordinated exit. When preparing for a discharge, the common mistake a family makes is relying on a flawed question: who is available to pick us up? That frames the problem around convenience. The question that matters is, what kind of ride does this specific medical condition require? Asking the correct question creates positive ripple effects. Hospitals clear beds without waiting for poorly equipped family cars. Caregivers avoid strain, and patients arrive at their destination safely. When the transportation plan respects the physical reality of the passenger, they are treated as a recovering individual rather than cargo. The transition from the hospital exit to the front door is the final physical step of the discharge plan. When handled with professional support, it allows the recovery process to continue uninterrupted.